What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May.
All right, today we're tackling the update. You know the one. The 2025 American Heart Association Guidelines for CPR and ECC. ACLS 2025.
Yep. The manual that basically rewrites the script for our most intense moments. Every 5 years it lands, and suddenly things we thought were standard practice, well, they changed.
Exactly. It's like the ultimate clinical stress test manual, isn't it?
Yeah.
So our mission today is simple. Break down the biggest shifts from 2020.
Right. We want you walking away knowing the key differences, the why behind them, so you're ready, instantly up to date.
We're going to cover some major changes in electrical therapy, a bit of a surprising shuffle in vascular access, some nuance in drug timing, and then this huge new focus on what happens after the arrest and even system-level stuff.
It's a big scope this year, so where should we start? Electrical therapy.
Yeah, let's start there. Defibrillation, always core. What's new with the energy settings? I hear they're getting less timid.
That's a good way to put it, especially for synchronized cardioversion. Think atrial fibrillation, atrial flutter.
Okay.
The new guideline says for AFib, using biphasic defibrillators, an initial shock of at least 200 joules is reasonable.
At least 200. That's quite a jump from maybe starting lower.
It is. It's a definite push. No more starting at 50 or 100 and escalating slowly for AFib.
So what's driving that? What's the evidence?
It's about getting it right the first time. Efficiency, really. Big trials showed that starting higher, 200 joules or more, gets you over 90% first shock success.
90%, wow.
Yeah. And think about it. Fewer shocks mean less total energy, potentially less myocardial stunning, and definitely less time under sedation or anesthesia for the patient.
Right. Less messing around, quicker resolution.
Yeah.
Makes sense. Okay, what about the really tough cases? Refractory VFib or pulseless VT?
The ones that just won't break after, say, 3 standard shocks.
Exactly. People talk about double sequential defibrillation, DSD, or changing the pad placement, vector change. VC, what's the official word now?
They've put the brakes on pretty hard. The guidelines explicitly state the usefulness of both VC and DSD is not established.
No, established. But you hear anecdotes, right? Teams swear by it sometimes. Why so cautious if it might work?
They actually address that. The key insight, they say, is why the rhythm often comes back after a shock. About 80% of the time, it's actually refibrillation.
I mean, the shock worked, but the heart just goes right back into VFib.
Precisely. It's not that the electricity failed, it's the underlying heart condition reasserting itself almost immediately. DSD and VC, theoretically, are for that small subset where the electricity truly fails to terminate the rhythm.
Okay, so we don't have good data to pick out that small group yet.
Exactly. So the risks, the complexity, the potential delay in setting up 2 machines, it doesn't justify routine use for everyone. Stick to high-quality basics first.
That distinction is critical. Refibrillation versus true electrical failure.
Got it.
Right. What else is being discouraged or limited now?
Well, head-up CPR, it was generating some buzz.
Yeah, the idea of improving brain drainage during CPR.
Right. But the 2025 guidelines explicitly discourage its routine use outside of clinical trials. The evidence just didn't stack up for widespread adoption.
Okay. And POCUS, point-of-care ultrasound in a code.
Still potentially useful if you're experienced and looking for reversible causes like tamponade or PE. But there's one absolute rule.
Like stop compressions.
Bingo. It must not interrupt chest compressions. Any pause, even for a second, to get a view, probably cancels out any benefit you might get. Keep those hands on the chest.
Good reminder. They also cleaned out some old stuff, right? Like ET drug administration.
Yeah, that's gone. Giving drugs down the endotracheal tube is just not recommended anymore with better access options available.
Perfect lead-in. Let's talk access and drugs. Big changes in where we stick the needle first.
Kind of a back-to-basics shift here based on recent large trials. AV access is now firmly first line.
Intravenous first. I thought IO, intraosseous, was really pushing ahead for speed and reliability in codes.
It was, and IO is still absolutely the reasonable alternative if you can't get IV access quickly or if it fails. It's not like IO is bad.
Okay.
But the newer, bigger evidence showed IV access had slightly better odds of achieving sustained ROSC return of spontaneous circulation.
Slightly better. Is it clinically significant enough to warrant delaying drugs while struggling for an IV when an IO is often so quick?
That's the clinical judgment call, isn't it? The guidelines prioritize attempting IV first. The thinking might be that a well-established peripheral IV might be more reliable long-term during transport or ongoing resuscitation compared to an IO, which can sometimes have flow issues or get dislodged.
Okay, so attempt IV first if feasible, but don't hesitate to go IO if needed.
Exactly. IO remains a critical tool.
All right, epinephrine, still the cornerstone drug, I assume.
Absolutely. Epi is still central, but the timing is now much more clearly defined based on the initial rhythm. It's not just give epi every 3 through 5 minutes.
Okay, break that down. Shockable versus non-shockable rhythms.
Right. For non-shockable rhythms, so asystole or PEA, the recommendation is give epinephrine as soon as possible, ASAP.
Get it in fast. Makes sense. Need that perfusion pressure.
Exactly. But for shockable rhythms, that's VFib or pulseless VT,
You wait.
you prioritize CPR and the shock first. Give epinephrine after the initial defibrillation attempts have failed.
Why the delay there?
Because electricity is the definitive treatment for shockable rhythms. You don't want to pause compressions or delay that potentially life-saving shock just to draw up and push epi if the shock itself could fix the problem. Shock first, then epi if needed.
Got it. Shock first for shockable, epi ASAP for non-shockable, and vasopressin still hanging around.
Nope, it's effectively out for cardiac arrest. The evidence is clear. Vasopressin, either alone or combined with epi, offers no advantage over just using epinephrine alone.
So simplify the drug box, just epi.
Pretty much. And for shock refractory VFPVT, if you need an antiarrhythmic after epi and shocks aren't working.
Amiodarone or lidocaine?
Those are the two. They may be considered. Other agents people sometimes ask about: beta blockers, procainamide, sotalol. The guidelines say their benefit is uncertain. Stick with amio or lido if you're going that route.
Okay, clear enough. Let's shift gears slightly to managing unstable rhythms before arrest, peri-arrest, and also that tough call on when to stop.
Yeah, the peri-arrest stuff is important. Key takeaway. Arrhythmias can cause instability, but they can also just be a symptom of something else going wrong, like sepsis or hypoxia. So quick stability assessment is crucial.
And for wide complex tachycardia if the patient is unstable.
Synchronized cardioversion, that's the immediate treatment. But there's a huge warning here, something everyone needs to remember.
Don't give calcium channel blockers.
Exactly. Do not give verapamil or diltiazem for undifferentiated wide complex tachycardia. If it turns out to be VT, you could cause profound hypotension or even cardiac arrest. Big danger zone.
Critical point. And polymorphic VT, like torsides.
That's always considered unstable. Immediate defibrillation, unsynchronized shock. Don't try to synchronize that chaos.
Right. Okay, now the hardest part. Termination of resuscitation. TA or rules? Any refinements?
They've refined them based on the level of care available, BLS versus ALS providers, and there's a universal rule, too. It acknowledges the different realities on the ground.
Practical adjustments. What about using end-tidal co-RO? That little number telling you about perfusion. Can a low number alone justify stopping?
No, absolutely not in isolation. ETCOs should not be used alone to terminate efforts.
But it's still useful.
Very useful as part of the bigger picture. For an intubated patient, if the ETCO stays consistently below 10 mmHg Hg after 20 minutes of good ALS resuscitation.
Less than 10.
Yeah, that indicates very poor perfusion, very low cardiac output. It's a strong factor suggesting resuscitation may be futile, but it needs to be considered alongside everything else. No ROSC, initial rhythm, downtime, etc.
Makes sense. Part of the picture, not the whole picture. Okay, let's get into what feels like the biggest philosophical shift. Post-cardiac arrest care and the long game.
This is where the guidelines have really expanded. It's not just about getting a pulse back anymore. It's about the quality of survival.
So after ROSC, what are the immediate priorities?
Avoiding hypotension is paramount. Maintain a minimum mean arterial pressure, MAP, of at least 65 mmHg. Below that, you risk underperfusing the brain and other vital organs. Keep that pressure up.
MAP goal of 65.
Yeah.
Got it. And temperature management. Therapeutic hypothermia used to be the term.
Now it's more broadly temperature control or targeted temperature management, TTM. The recommendation is it's reasonable to maintain a temperature between 32 and 37.5 degrees Celsius.
That's a wider range than before.
It is, and maintain it for at least 36 hours if the adult patient is still unresponsive after ROSC. That extended duration is aimed at neuroprotection.
36 hours. Okay. Diagnostics. What should we be looking for once they're stabilized?
For survivors where you suspect a cardiac cause, especially if they had a shockable rhythm, coronary angiography before discharge is highly recommended. Find and fix the plumbing if that was the issue.
Makes sense. Cath lab evaluation.
Yep. And things like CT scans, head to pelvis, and bedside ultrasound, POCUS, or echo are reasonable to look for the underlying cause or complications from the arrest or resuscitation itself.
Now, the really new frontier, survivorship and ethics. This feels like a major broadening of our scope.
It really is. There's a huge emphasis on the recovery phase. The guidelines state that survivors and their caregivers need structured assessment for things like anxiety, depression, PTSD, cognitive issues. And they need treatment or referral for these issues before they even leave the hospital. We have to address the aftermath, not just the event.
That's a significant responsibility shift. And it ties into the new ethics chapter, right? Addressing disparities.
Exactly. It's not just about individual patient ethics anymore. There's an imperative for healthcare professionals and especially healthcare organizations to actively address inequities rooted in social determinants of health.
How does an organization do that? What's a concrete example?
Well, recognizing that survival rates are often lower in certain neighborhoods, maybe due to less bystander CPR or longer EMS response times. So an organization might need to target those areas with more public CPR training, work to get AEDs placed strategically, or analyze and improve EMS dispatch protocols to ensure fairness.
So it's about system design, not just bedside care.
Precisely. It's looking at the whole system to eliminate disparities in cardiac arrest outcomes.
Okay, so if we wrap this all up,
Yeah.
what's the big theme of ACLS 2025, if you had to distill it?
I'd say it's about precision in the core interventions, higher energy for AFib, clear epi timing, IV first, while being cautious about unproven stuff like DSD, nailing the basics.
Excellence in the fundamentals.
But then there's this huge expansion, recognizing that ROSC isn't the finish line. The focus on long-term recovery, brain health, emotional well-being, and tackling those systemic inequities. That's the other major theme.
Yeah, it feels like the definition of success in resuscitation is getting broader.
Definitely. And maybe the most provocative thought is this. The biggest change in these guidelines isn't really a specific drug dose or joules setting.
What is it then?
It's the formal recognition that our responsibility extends way beyond the code room. It stretches into long-term survivorship, into community health, and into the social and ethical frameworks that ultimately determine who gets a better chance at survival.
That's a powerful way to frame it. Our mission just got bigger.
Well, thank you for walking us through that. This has been incredibly helpful.
Absolutely. Hope this deep dive helps everyone feel more confident applying these crucial updates.
If you found this valuable, please do subscribe and share the channel with colleagues. We'll catch you next time on What the Study Says.